So we are the only children's hospital in Northern Ireland. We're a regional and tertiary referral centre, and we're also the paediatric general hospital for our local population. The emergency department, it's completely separate from the adult ED, and it's at the opposite end of the Royal Hospital site. We see approximately 34,000 children per year. We see children from birth up to the 14th birthday for new patients, but many of our children with chronic conditions remain under paediatric care until the 16th birthday, whenever they transition over to adult services. It's planned to increase our age from 14 to 16 when the new hospital opens, and this will be in close liaison with the adult teams. We're the best performing emergency department in the Belfast Trust, and we're the second best performing ED in the province based on the most recent figures. We have had no 12-hour breaches from May 2013, and we are consistently above 95% within the 4-hour target. We provide family-centred care, and that is at the heart of what we do. All the nursing staff are paediatric trained, and the consultant medical staff are paediatricians with subspecialty training in paediatric emergency medicine. There's a strong ethos of continual professional development in both the medical and the nursing teams. We constantly examine our practice and follow recommendations from external review bodies. To this end, we recently, January this year actually, we opened an 8-bedded short stay assessment unit, and this has greatly improved patient flow. All of the staff are keen to explore and introduce new clinical practices to improve patient care, and in fact we recently won the Chairman's Award for the introduction of a new treatment for buccal fractures in children. We aim to treat all children individually. We have separate cubicles to see the child and family, and no child is ever left to wait in a public area on a trolley. The emergency department and the RBHSC has a strong culture of openness and honesty with families and reflection of practice. Staff are encouraged to use the Trust incident reporting system, and this is used on a regular basis by staff. And there are regular morbidity and mortality meetings, which are multidisciplinary. That's
okay, thank you. That's really helpful. If I can kick off, and feel free to, whichever you think is the right individual to answer, or if you want colleagues to augment this. But what if you just take us through, first of all, what you see as the key issues facing the hospital in terms of resource, both resource and non-resource issues. So what are the key resource issues? What are the key non-resource issues that face you at the moment?
Well, I'll maybe start off. Resource issues, probably the main one that we would highlight would be staffing issues. I think same as many emergency departments, our staffing levels would be less than we would like. There has been a significant improvement in the last few years, both from a medical and from a nursing point of view, with recruitment of extra numbers of senior and junior staff. But when we're benchmarked against other departments, we still are beneath the benchmark levels. So this is partly a resource issue, but also a recruitment issue. Obviously, working in an emergency department is generally seen as being high intensity and high stress. And there is a difficulty in recruiting both general paediatric nurses and paediatric emergency nurse practitioners. And also from a medical point of view, we have experienced difficulty in recruiting middle grade paediatric emergency department staff. Other resource issues, staff or space is an issue within our department. And again, as Mandy's mentioned, this has improved somewhat with the opening of our short stay unit. So this has helped patient flow and reduce waiting times. We also with increasing of our nurse practitioner staff, have commenced a minor injury stream, and again this has improved flow and helped reduce crowding, but space can still be an issue, and again we see that that may not be able to be improved significantly until the opening of the new children's hospital. Non-resource issues, generally we feel that the hospital works very much as a team. The emergency department work well with other specialties, and generally the ethos within the hospital is to give the best care possible to the patient, and generally that works well. I think that would be the main thing.
Yeah, and in terms of other non-resource issues, what are the kind of challenges that are not ones that simply require money to deal with, but perhaps other ways of dealing with things? Either of the other two, in the kind of nursing side or management side, are there any particular issues?
Some of the non-resource issues, well, Liz has already mentioned about nursing staff, and it's difficult to recruit paediatric nurses because they're a scarcity. So we do have difficulty recruiting. We are hoping to recruit some new nurses within the coming month. We have some issues in relation to staff training. The training is available, but it's not always possible to release staff, and I would see that as a non-resource issue because, as I say, the training is available to us, but because of the scarcity of nursing staff, at times it's difficult to release people for training.
Okay. Thank you. My second question really is just about, can you tell us a little bit about how you make the hospital child-centred? And I'm thinking in terms of communication, management of pain, fluids, issues that have a particular kind of specific need for dealing with this in children as opposed to adults. And just take us through how you handle those issues. Well,
we'll work very closely with the family. It's not just working with the child, it's family-centred care. So the child will always come with a parent or guardian. And right at the outset, as soon as they arrive in the emergency department, they're assessed by a nurse, and it's an experienced paediatric nurse, so they will assess what the child's needs are while they're going to be waiting. So we would offer fluids if they're allowed, as long as they're not fasting. We give ice lollies, juice, things like that. We have nappy changing facilities. There's a shop and a coffee dock if parents require food themselves. If we have children, for example diabetic children, who are in the department for a length of time, we can get meals for them from our kitchen in the children's hospital. The kitchen staff are excellent providing that. Also for mothers who are breastfeeding, we can get meals for them as well if need be. We have a play specialist who is part-time, and we use her a lot to help the children deal with things that they're going to have to go through, distressing procedures. So she would use distraction therapy with them. We also have teddy bears that we give to all the children that are going through distressing procedure, and those are donated to us by the Freemasons and the Mothers Union. Also provide teddies for the children, and these, it seems such a small thing, but the children and the parents absolutely love them. So they're very important. We have toilets, plenty of toilet facilities available. With individual cubicles, so they're not put into a cubicle with another set of parents or children. The triage is in a separate room as well, so there's confidentiality maintained throughout their journey.
I think from a pain relief point of view, you mentioned all our triage nurses are able to prescribe pain relief at the time of triage, so even if the children have a wait to be seen and assessed by medical staff, their pain should already have been addressed, so they can be prescribed simple analgesia. We've also recently introduced the use of intranasal pain relief intranasal diamorphine, and that's to try and give as immediate pain relief as possible, and also to reduce the use of intravenous pain relief, which obviously can be quite distressing for children if that's the only reason that they need to get intravenous cannula. So we're continually looking at ways of improving the care. I suppose because all our patients are children, then it's sometimes hard to know what we specifically do for children, because it's what we do all the time. But obviously with different ages, there are things that are more appropriate for one group than another.
And this is just a very final, quick, related question to that. In terms of then elsewhere in the accident and emergency system, where you've got children obviously then accessing emergency departments that are for both adults and children outside of the Belfast Hospital for Sick Children, are there any suggestions that you'd have for how those facilities are made more child friendly? You've clearly got a very strong child focus elsewhere. When dealing with adults and children, it strikes me that they may well not have anything like the same child focus. So what are the kind of things you think should be, that you have done, that perhaps should be introduced across the piece?
Well, I think separate waiting area is vital for children, so that they're not subjected to distressing sights or sounds of an adult emergency department. They should have paediatric nurses available on every shift that can advise them in relation to childhood illness and injury. And I think play specialists actually would be very useful in other emergency departments, because they work very closely with the child and family, and they do a lot of work actually before we even see the child. So for example, if a child needs venipuncture undertaken, they will do some preparatory work with them. So we found them great benefit. So I think other emergency departments, it would be of benefit depending on the number of children they see.
Okay, thank you. Marion?
Good afternoon. Only two questions, please. One of them is about particular groups of children, say for example those with a disability or those with an acute mental health crisis. Could you set out what the ED journey is for those particular groups of children? How responsive you feel you are to their needs, and if you have any ideas that would develop your service further?
Well, I think certainly children, we have a lot of children who come with complex needs, and we do at the Children's Hospital have packages in place for many of them. Their consultants have written up care plans which we have immediate access to in the emergency department, so that we can treat them very quickly, and a lot of them have access to their own team, so a lot of them go directly to wards without having to come to the emergency department. So that works for some, but not all of the children. The children that come to us, we try and deal with them as swiftly as possible. And what was the other part of the question? Mental health.
Yeah,
mental health.
From
Just one, if I could mention one thing about mental health issues. Since we've increased our age group to 14, we have seen more children with mental health problems and self-harming. The one problem we do have is that our nursing staff wouldn't have formal training in dealing with those. Now we have accessed some training from some of our CAMS colleagues, but we don't have any nursing staff specifically trained in dealing with those, and we do find it very challenging. We find it a challenge because of the lack of space as well in the department where to put these children.
I mean, children who attend with mental health crisis, we do have, well, for self-harm, we do have a care pathway which was drawn up in conjunction with the CAMS team several years ago, which we try to work with. Generally, all children who present with self-harm are admitted. That would be the NICE guidelines that all children who present. So we do generally concur with that, and we generally have good support from the CATE team, the Crisis and Assessment Intervention team. So since it's been set up and been available at all hours, that has made a significant difference. The CAMS back up, it can be difficult at times, particularly for acute presentations, but Kate have bridged that gap to some degree. But as Mandy says, it is a training issue, not just with nursing but with medical staff, and it's one of the issues that we've highlighted, which obviously, particularly if our age range does possibly go up to 16, particularly with the new hospital, it is something that, you know, we are already discussing what training issues that will involve.
Mm-hmm. In terms of suggestions for improving practice, I mean, obviously the access to mental health personnel for children who self-harm is something you're highlighting, but is there any other areas you would want to highlight?
No, I mean, I think all our, you know, all patients who attend, they all have to be treated as individuals. We can't have a blanket policy for what we do with them, because obviously they're all very different. Some of them will already be known to services, and some will be newly presenting and be an acute crisis. So I think we have to just liaise with the you know, a lot of it is the family as well as the patient, considering the age that we're seeing. So as I say, it's just formalising the pathways and maybe getting a little bit more training would be the big issues.
My final question is in terms of staffing, and you've already both noted difficulties in terms of both medical staff and nursing staff. But how is, or could you explain how the skills mix and the number of staff are monitored within our BHSC, the emergency department, and how plans are made to develop or increase numbers?
Yeah, well, as we mentioned before, we have had a few reviews done in the emergency department in the last number of years. So we had an IMAS review and we had a NIMTA visit, looking at lots of issues, but obviously staffing was one of those that was highlighted. So both reviews, I think, reported back on the commitment, the enthusiasm of the staff, the good training that was provided, but that generally it was felt that the staffing numbers were below the ideal. So we have had significant increase in staff, as I mentioned before, both from a senior medical and more junior medical, and that's been in conjunction with the medical training. Our junior staffing have increased, and again with nursing team, there was concerns regarding smaller numbers than should have been of the more senior nurses, and that has been addressed too. But recruitment is a big issue with that. Our staff mix, from a medical point of view, we do have both middle grade and senior presence in the emergency department from 9 in the morning, 8:30, 9 in the morning through to midnight, and that's most nights. We occasionally, with if there's sick leave or prospective annual leave, we may not be able to provide that every night, but most nights consultant staff work a weekend cover as well. We provide shop floor cover at that time as well. So there is good support for junior staff with that. From
a nursing perspective, we have a senior nurse on call 24 or on the floor 24 hours a day. So we had a recruitment of band 6 nurses, senior nurses, a number of years ago, and that has worked very, very well. Issues with skill mix is a problem on and off, so it's monitored on a daily basis, and it depends, as Liz has mentioned, on sickness. Currently we have a lot of maternity leave, and we do have some vacancies, so it has to be monitored daily. The management team in Sick Children's are very supportive, and we have meetings Monday to Friday every morning with a manager on call, looking not only at the skill of mix of staff but of the bed availability. So it's monitored on a daily basis, and then the ward sisters will have a regular meeting with their line manager to monitor staff sickness, maternity leave and recruitment. So it's monitored quite well.
Can I just ask you, you mentioned their support. What support systems are available for medical and nursing staff who work in ED at the RBHSC?
Well, for the nursing staff, I mean, as I said, we have our line management support, so our managers are there and available every day. They're also on call, so Karen and her team will have a rota, and they're available 24 hours a day. We also have a patient flow manager who's there 24 hours a day, so that is available for myself or my senior nursing team if they have any concerns. There's always someone available for them to call on if they have any concerns.
From a medical point of view, as I say, we do have senior presence within the department up to midnight. There is a consultant on call 24/7. When there isn't a senior presence within the emergency department, there is several registrars within the hospital, both surgical, anaesthetic and medical, and it would be their responsibility to cover the emergency department in the hours when there isn't senior cover there. Other clinical support that we provide, a consultant will review the notes from the previous 24 hours every day, both during the week and at weekends. So we go through the notes, review the treatment that has been given, and if there's any issues that have been highlighted or follow-up required, we will do that. So that's the clinical support, and then obviously other support staff, our permanent medical staff are all involved in annual appraisal. So that encompasses quite a lot of review of practice, of numbers, of any issues that have raised. Also things like continuing professional development and training would all be reviewed at that. Our more junior medical staff then would all have clinical and educational supervisors and would have regular meetings with them.
Thank you very much. Thank you.
Paul?
Just one short question, if I may. I'm sure you know about the April-June 2014 summits. I think they're organised by the College of Emergency Medicine. And out of those arose some recommendations for emergency care in Northern Ireland. I think there were 18 key recommendations. This isn't a test. If you don't know the recommendations, that's fine. But I'd be really interested to know, if you do know the recommendations, those 18 recommendations that were recently published, I'd be really interested to know, what you thought of them, whether you thought they were very apposite and helpful. When I'm not an expert on these things, you are. When I read them as a non-expert on these matters, I thought they were a little light on children, actually. But I'd be interested to know if you have any reflections on those 18 recommendations, whether you thought they were helpful contributions.
The summits that occurred, I was actually present for the initial summit. We weren't invited back for the second summit. So sometimes the Children's Emergency Department does get forgotten about, which is sometimes good, but other times we do miss out a little bit. So we haven't been actively involved in drawing up or participating in the drawing up of those. I have seen, I've read them. Certainly I wouldn't have any problems with any of them. I think they're all good things to aspire to. We haven't been actively involved with that.
I'm not trying to put words in your mouth, but did you think that they were a bit light on the children's dimension of emergency care?
Yeah. There certainly wasn't anything specifically for children. Obviously some of the things, some of the big issues that have raised concern about emergency care, we have managed to improve and avoid, things like the 12-hour breaches, the trolley waits, all those things we have never felt would be acceptable in the care of a child, and everyone in the Children's Hospital has worked to their utmost to try and prevent any of those things occurring. So I suppose sometimes we feel like we sort out some of our problems ourselves, but yes, I don't think there was very much that was specifically directed to children in those. But things like, recruitment of staff, retainment, making, the job able to be done, those things are obviously, apply just the same to our department as anywhere else.
Thank you all, appreciate it.
Thank you. There's an opportunity if you'd like to say anything else, or you think we've missed anything that you'd want any points to make before we finish the evidence session.
Yeah, I think we just like to say we're very grateful to be given the opportunity to come and talk about the department. We're aware that emergency departments often get bad press, and often justifiably so, but I think sometimes they're all clumped together, and we hope that we've managed to convey to you that we're generally quite proud of our emergency department, and generally both clinical and non-clinical staff are very committed to and enthusiastic about the care of the child, always trying to strive to improve the service, but generally proud with the way we manage our department.
Okay, well, I'm pleased that given that Children's Hospital Emergency Department sometimes gets forgotten in the system, that we haven't forgotten you. So, look, thank you very much. That's been really helpful. And thank you for coming in this afternoon.
Thank you very much. Thank you.